Hello, my name is Christine Ho, and today I will be talking about the impact of the Patient Protection and Affordable Care Act, otherwise known as the Affordable Care Act, on tuberculosis control. So I want to start off just by a polling question to ask how much you already know about the Affordable Care Act. So please just let me know if you know nothing, a little, some, or you're very familiar with it, or you are expert. And what I see is about 13% of you said that you know nothing about the Affordable Care Act, 37% a little, some, 33% said they know something about the Affordable Care Act, and 6% said that they were very familiar, and 0% said that they were expert. Well, I'm also not an expert at the Affordable Care Act. It is a very complex piece of legislation, but what I'll do today is go forth and try to describe this to you in a way that is understandable. So the objectives are, 1, to describe the Affordable Care Act in simple terms that you can understand. 2, the impact of this law on TB control. 3, the TB program's continued role. And 4, how programs could strategically leverage the opportunities that are presented by the Affordable Care Act to ensure TB services. So really, what we're going to look at is who is covered under the Affordable Care Act and how, what services will be covered, where the services will be delivered, and how the evaluations will take place to be able to inform the process. So again, what I'm going to be doing is describing the covered services under the Affordable Care Act and looking to see where those services are going to overlap with the essential components of a TB control program. And to notice that there are aspects or components of a TB control program that are not affected and do not intersect with the services that are covered under the Affordable Care Act at all. But for the services that do intersect, what we want to do is see if we can use that to actually leverage public health using this much larger personal health care system in order to achieve population health goals. So we're going to start with who is covered under the Affordable Care Act. So adult children ages 26 and under can now be covered by parents' plans with an estimated addition of a little over 3 million young adults that would be newly covered. The Affordable Care Act also expands coverage, and it really does it in 2 ways. The one way in states that choose to expand Medicaid is to provide Medicaid to those people who earn 138% of the federal poverty level and below, that they would be able to be covered under Medicaid, the new Medicaid. And for the other folks from 100% of federal poverty level and above, that they have the opportunity to be insured under new quality health plans that would be offered through the exchanges. And these would be offered either through individual health plans or through their employers. As well, the Affordable Care Act offers new consumer protections and choice, and it generally prohibits the denial of coverage based on pre-existing conditions for children now and adults for the plans starting in 2014. It prohibits rescission or the dropping of coverage retroactively, and it bans lifetime and annual coverage limits and restrictions on out-of-network ER usage. Okay, so here is a second question. Which statements are true in terms of participation of states with the Affordable Care Act? A, all states must participate in implementing the Affordable Care Act in its entirety. B, states can refuse to implement the Affordable Care Act completely. C, although the Affordable Care Act will provide health insurance for many who are uninsured, there will be some that will remain uninsured. D, all of the above. E, none of the above. Okay, and what we saw was 4% answered A, that all states must participate in the Affordable Care Act in its entirety. 8% answered B, that states can refuse to implement the Affordable Care Act completely. C, 83% answered that the Affordable Care Act will provide health insurance for many who are uninsured, but that there will be some that remain uninsured. D, 18% answered all of the above, and nobody answered for none of the above. So the correct answer to this question is actually C, that although the Affordable Care Act will provide health insurance for many who are uninsured, there will be some that will remain uninsured. So the states have the opportunity to expand Medicaid eligibility to adults aged 19 through 64 with incomes up to 133, it's actually 138% of the federal poverty level. In states that opt to do that, federal funding is provided 100% for the Medicaid expansion through 2016, and then 90% thereafter. The states have no deadline for implementing the expansion. So the states are not mandated to expand Medicaid. They can decide to or not, but the Affordable Care Act is rolling out in all the states. So the other pieces in terms of the opportunity to sign up for quality health plans through the exchanges, that is available in every state. There will be one streamlined application for Medicaid and the quality health plans or the private health plans in the marketplace, or what is also known as the exchanges. And there is a simple way to be able to determine eligibility as well as look at the plans. So who won't be covered? Well, what we estimate is that in 2014, there will still be 44 million people that will not be covered under the Affordable Care Act, either because their states are not choosing to expand Medicaid or because they are not eligible, either because they are incarcerated, undocumented alien, or other reasons. So in 2014, the 44 million would be equivalent to the populations of Oregon and California. In 2015, 37 million would be estimated to still remain uninsured, and that's the populations of equivalent to the populations of Pennsylvania, New York, and Connecticut. 2016, there would still be 31 million, or the populations of Georgia and Florida put together. So the bottom line is that there is still a continuing need that is significant for safety net services for these people that will remain uninsured. I just want to remind you that prior to healthcare reform, states could add Medicaid eligibility for TB patients. They had the option to extend Medicaid eligibility to low-income persons that were infected with TB. The covered TB-related services include prescribed drugs, physician services, lab and x-ray services, clinic and federally qualified health center services, case management services, and other services such as services that were designed to encourage completion of outpatient regimens, so including DOT. There have been 9 states that have elected to provide this Medicaid waiver, this Medicaid expansion, and there is receipt of matching federal dollars for treating these TB patients. Okay, so a word about the marketplace or the insurance exchanges, and this is where the individuals or the employers would go to pick their health plans. This is so that the plans would all be in one place where you could actually compare not only the price, but the benefits, the qualities, and other factors. And this has not been available previously. The advantages of having a marketplace are that it helps enhance competition in the health insurance market. It increases affordability through the premium tax credits that are available for those persons who are enrolling in the quality health plans. And it also ensures quality because the quality health plans must meet basic standards, and these include standards on quality and performance, consumer protections, and access to an adequate range of clinicians. They also make the cost clear by providing information about the prices and the benefits in simple terms so that consumers can actually compare and make informed choices. Okay, so we're going to move on to what is covered with the Affordable Care Act. And here's the next question. Which of the statements are true? Now, A, the same coverage of services is required for all plans, for all states. B, for all plans within a state, there is a minimum requirement for coverage of services. C, there is a minimum requirement for all plans for coverage of preventive services. D, all of the above. E, B, and C, and F, none of the above. Okay. So we have 1% that picked A, 5% that picked B, 12% that picked C, 4% that picked D, 75% that picked E, and 2% that picked F. And the answer is E, it's B and C. So for all plans within a state, there is a minimum requirement for coverage of services, and there is a minimum requirement for all plans for coverage of preventive services. And we're going to go through that right now. It's a little bit confusing. So what preventive services must be covered under the law? So the law requires the following services to be covered without cost sharing. These are in the Medicaid Expansion plans and the quality health plans. And it is all preventive services that have been given an A or B grade recommendation, so highly recommended or recommended by the United States Preventive Service Task Force. And this is a task force that is composed of objective reviewers that review many preventive health services and provide recommendations on whether primary care providers should be screening their patients for these diseases or not. So LTBI screening of high-risk persons had an A grade in 1996, but because of a change in methodology and how they came out with the recommendations, in 2002, instead of regrading LTBI screening, the United States Preventive Service Task Force deferred to CDC for these recommendations and left this activity ungraded. At that time, there was no impact, but at present, because of the way that the Affordable Care Act covers preventive services, left ungraded, LTBI screening is not covered without cost sharing. The other place where preventive services must be covered without cost sharing are all those recommended under ACEP, or the Advisory Council on Immunization Practices, and HRSA, Health Resources and Services Administration. And for TB, this recommends TB testing for children at high risk for TB. Okay. So besides the preventive services that are covered under the United States Preventive Service Task Force, or ACEP and HRSA, all qualified health plans must cover these 10 essential health benefits. So here are the categories of the 10 essential health benefits. You can see them: ambulatory patient services, ER services, hospitalization, maternity, mental health, rehab, lab services, preventive and wellness services, etc. Okay, but what is, let me go back, but what is actually covered, what specific services are covered in each of these 10 essential health benefits is not specified. And what IOM, the Institute of Medicine, decreed is that This will be decided on a state-by-state basis. So each state has chosen what's called a benchmark plan, and that is one health plan chosen from a proscribed list of 10 insurance plans that will basically set the benchmark of what must be included in that state. So for all the quality health plans in that state, they must at least meet the minimum requirements of having the same coverage as their benchmark plan. So, for example, if I'm just going to throw out something. So California has Kaiser Small Group 30, I think, as their benchmark plan. They will have services covered in each of these 10 categories. Every one of the new quality health plans that is in California needs to at least meet the minimum of those services. It gets a little more complicated than that, but that's basically the structure of how the coverage is determined state by state. Okay, so now let's move on to who is going to be providing the services. So now we come to a term called essential community provider, and your next question is, who could be an essential community provider? A primary care provider at a health center, B, a private provider who cares for low-income patients, C, a health department provider, or D, any of the above. Okay, so 2% of you said a primary care provider at a health center, 2% said a private provider who cares for low-income patients, and then the majority, the rest of you, said any of the above, and you're right. So the law requires that the new quality health plans that are offered through the marketplaces or the exchanges include in their networks those essential community providers were available that serve predominantly low-income, medically underserved individuals. It's a way to ensure that there will be healthcare providers, doctors, nurse practitioners, etc., physicians, extenders, that actually serve the individuals that will be the newly enrolled, the newly insured. CMS regulations provide that a QHP issuer must have a sufficient number and geographic distribution of essential community providers to ensure reasonable and timely access to a broad range of such providers. So HRSA identifies essential community providers and includes those that are eligible for the 340B program. This is a federal drug discount program. So one of the ways that TB programs can ensure that their clients, those at highest risk for TB, are going to be cared for by providers that will be taking care of those newly insured that may be at high risk for TB is there are several ways. One is that the TB programs can become a member of an accountable care organization so that they are part of the organization that actually cares for these high-risk individuals. They can also identify additional hospitals, clinics, or practices that evaluate and diagnose TB suspects and cases and ensure that these facilities are designated as essential community providers. And by having those providers on the provider panel of the quality health plans, the new insurance plans, then you're making sure that the newly insured patients are going to providers that know how to screen for TB and test for TB. Now here's an example. So we have Urban County A, and we look at their TB cases, and they're a mix. They have foreign-born cases that are a mix of newly arrived and settled immigrants or refugees. And the medical services for these folks are mainly through the refugee clinic, as well as a federally qualified health center or other community providers. There are also U.S.-born cases in the area that are concentrated in an area with shelters and treatment facilities. There is one FQHC and several nonprofit clinics that serve this area. So some options to optimize TB screening and evaluation would be, one, to have the nonprofit clinic affiliate with an accountable care organization that could be an academic medical center or a consortium and bill for services. The TB program could partner with the FQHC and refugee clinics to do TB screening and evaluation, and those clinics could bill for services, or the TB clinic themselves could get 340B or FQHC status and bill for services. Okay, so now we're going to move on to the last question, which is how is evaluation going to take place in order to inform the process? So we're going to get to a piece of the Affordable Care Act legislation that really seeks to encourage and maximize the use of health information technology in order to be able to perform evaluation. And CMS had has an incentive program, actually still in place, encouraging providers and facilities to move to electronic health records. This is called meaningful use. And there are requirements to be able to receive those incentives. And the requirements are that they must use an information technology system that has these characteristics, that use structured fields, that use something called clinical decision support tools, which I'll go over in a few minutes, that report on clinical quality measures and communicate relevant health information to patients. The systems must be able to provide patients' ability to view their health information, and they must be able to provide summary of care records for transition and referrals. So, for example, you may already yourself be seeing a provider who now allows you to get your laboratory information by logging in to your account. That would be an example of a facility or an organization that has complied with the meaningful use requirements. Or if somebody went to an ER in Hospital A, that hospital may be able to get laboratory records or summaries from Hospital B if you had been seen there earlier, etc. Okay, clinical quality measures are measures that in the future, providers will be asked to choose from a list. So there'll be a list of clinical quality measures, and providers can choose on them. And if they've chosen, whatever they've chosen on, they will work on improving those measures. And if they can improve those measures, there's an additional incentive. So what I wanted to do is I wanted to just share some of the measures that HIV has been working on, and these measures are already in the endorsement process. You can get a sense of what these clinical quality measures are. So for HIV, some measures are the percent of patients seen at least once during a 12-month period with a suppressed viral load, the percent of patients seen at least once during a 12-month period on antiretroviral therapies, percent of patients with a visit every 6 months over 24 months, and a percent of patients with gap in care over a 12-month period. So you can see that if there's a facility that took care of a lot of HIV patients and they chose to focus on one of these clinical quality measures, these are measures that are really looking at encouraging continuity of care for patients with HIV, that they get viral loads, and that their viral loads are suppressed. And I think it's important just to share this because I think that we in TB could be provided an opportunity by looking at clinical quality measures for ourselves. So perhaps with screening for latent TB infection in, either health centers or other provider settings where there's a lot of patients that would be at risk for TB infection and disease, that could be very fruitful. Clinical decision support is a process for enhancing health-related decisions and actions with pertinent, organized clinical knowledge and patient information to improve healthcare delivery and health. So an example would be that a patient would have their smoking status noted in their electronic health records. And for all those patients that are smokers, medical assistant, as the patient is being checked in, may talk to the patient and offer them referrals or resources for stopping cessation programs. So that would be a very simple and clear example of clinical decision support. So clinical decision support can support retention and re-engagement in care. If you have patients who are lost to care and are lost at follow-up, you could have a flag in there, and if that patient is seen in a different clinic or in urgent care, they can be re-engaged. It could be good for self-care and treatment adherence, also data collection and bidirectional reporting and communication, performance measurement and improvement. And I do believe that Dr. John Bernardo actually has a publication using clinical decision support for LT-BI screening that showed really good success, and actually. Okay, so we are now going to move on to billing, and billing is not part of the formal infrastructure for the talk on Affordable Care Act, but it's actually very important to discuss because it is one of those areas where we can perhaps leverage in order to gain more support for the public health services that we provide. So first, the question that I ask to you is, does your program bill for services? Yes, for all services. Yes, but only certain services. No, not at all. You do not provide clinical services, or not sure. Okay, so I see that most of you come from programs that bill only for certain services or not at all. Okay, so just to simplify this explanation, I'm going to go through a very common scenario. Before the Affordable Care Act, most health departments do not bill for services, and they provide services to clients regardless of their ability to pay. So here you have the health department and providing services to all the people that are, below where the arrow is pointing. And these two persons to the right in the yellow boxes represent patients that might be insured. And so they have coverage for services, but because there's no second or third party billing, the health department does not recoup any funding for those services or any money for the services that were given, and it results in a financial loss for the health department. Okay, so one option is that the health departments continue to provide clinical services to clients. Some clients are insured, but the health department develops the ability to bill and can bill those health plans for services. And in that way, the patients may want to go to the health department for convenience or other reasons, but the health department will recoup some monies for the services that are rendered. Another option under the Affordable Care Act, you'll have a greater segment of the patients that were previously uninsured that may now be insured. And so when you bill, they are able to recoup monies from not only the existing health insurance plans, but also the new quality health plans. Okay, so the new health plans that are in existence from the Affordable Care Act. So these patients have signed up under the exchanges, they're newly insured, and they can collect monies from them as well. Second option is that the health department cares only for uninsured clients. Okay, so the patients that are uninsured, okay, must now go seek services from outside providers that are listed on the health insurance plans. So one question is, how does the health department assure quality of services for these outside providers? And I think that we'll talk about this a little more in the future. Okay, now with the Affordable Care Act, there are more people that are insured, so they're the newly insured, okay, and they will receive care, again, not through the health department under this option, but through the essential community providers and other providers, network providers, listed under the quality health plans and perhaps under the Medicaid Expansion plans as well. One of the keys to note is that there are always uninsured patients that still need care, that nobody is going to be taking care of them if the health department does not take care of them. There have been a lot of activities around billing in the CDC and beyond. The National Center for Immunization and Respiratory Diseases, NCIRD, had an American Recovery and Reinvestment Act era-funded billing project where they actually had planning sites and implementation sites that looked at what we just looked at graphically, and that is billing for immunizations. And immunizations is a very nice activity to target because it's a procedure and, you know, easy to bill for, etc. It was a big success, and it's actually being expanded now. The thing that is very valuable about this project is that there were many sites that developed billing toolkits for their state, okay, for immunizations. But most of the materials that they developed are not, you know, they're not specific for immunization. They're really specific for billing for that state. So other diseases like TB can take advantage of these toolkits that have already been developed and really just go in there and, you know, have, I think NCRD is very willing to share the information and to use that information on billing and the insurance laws for those states, and just all would need to be done is just changing the codes for TB and also for other diseases. We've also had a billing roundtable in 2012. There are some billing activities within CDC. The American Health Insurance Plan has a 3-part billable project to support sites. And NACHO, the National Association of City and County Officials, has developed a billing toolkit that is undergoing a review and feedback from subject matter experts right now. So in sum, what I want to convey is that there's a continued role for public health. The populations that are most at risk for TB, those that are non-U.S. born, minorities, homeless, or persons affected by alcohol or substance abuse, have limited access to health care. There's ongoing transmission outbreaks and drug resistance that can result in contacts of infectious patients not being located or being treated for TB and LTBI, TB infection, and persons with TB diseases that are not treated completely if the role of public health is not continued to be supported. The guarantees for inherently governmental public health services were not the goal of the Affordable Care Act. It does not substantially decrease the need for these services by CDC and health department partners. What we in the world of TB and public health need to do to leverage TB services in the community are, I have outlined a few steps. One is to study the benchmark plan or alternative plan in your state to see what is and what isn't covered. 2, to identify health plans that serve populations at high risk for TB and work with those plans directly to cover TB-related patient services such as LTBI treatment. And to identify providers that serve individuals at high risk for TB. You can explore partnerships with these providers and just keep in mind the capacity of those providers, looking at things like turnover and what is realistic. What is a realistic partnership with these providers? So perhaps a partnership with a free clinic with a lot of turnaround, with providers of different levels of training might be very different than an FQHC with providers that are very stable, that have a lot of training in infectious disease or pulmonary medicine. I think as well, exploring future educational and quality assurance opportunities and needs in these settings is key in order to make these partnerships successful. And lastly, I would just like to acknowledge the following people for all of their work in supporting our work in looking at the Affordable Care Act and its impact on TB. There are folks in here from the CDC Center for HIV, Hepatitis, STD, and TB that provide a lot of support for us. That's Stuart Berman, Haley Stolp, Rosini Kazam, Lydia Ogden, as well as our consultant from George Washington University, Naomi Seiler, who's been a wealth of expertise for me and for everyone in the Division of TB Elimination. Thank you very much for attending our webinar.